The last case for that session is a 15-year-old girl with collapse, and I'll just tell you that she's had a seizure. So I'll talk a little bit about seizures now. And this particular girl has this EEG. So I thought I'd show you an EEG because you've maybe never seen an EEG. But this is what an EEG looks. It looks a lot like an EKG, just a lot more channels and a bit messier. So this is what it's kind of supposed to look like. And we have channels that are on the left side up here, and then some on the right, and then some more on the left, and some more on the right, in the front, in the more in the back, front, back. So we kind of look at different parts. And this is the abnormality here. And this is a polyspike and wave discharge. So you see these little spiky things, and then there's a slow wave. So that's a polyspike and wave discharge, and that's diagnostic generally for juvenile myoclonic epilepsy. So 15-year-old girl with that EEG, we are done with the workup. We do not need an MRI scan. That's the diagnosis, okay? I don't have other pictures, but if you have your childhood absence, it's the 3 hertz spike and wave. So they have pretty much the same duration of the, it looks quite similar to this, but it has only one spike. So one spike and wave. And then there's 3 of them in the space of 1 second. That's why it's 3 hertz. And a very, very synchronous, very kind of an elegant discharge, not as messy as that, and very easy to diagnose. So EEG is an absolutely invaluable tool in epilepsy. So diagnosing seizures, the first thing is to decide, is it actually a seizure? And that's, because you can misdiagnose seizures. Now, it's more common that people misdiagnose actual seizures for non-seizures than the other way around. It's because there are a lot of really subtle seizures that people don't recognize. So generalized tonic-clonic seizure is pretty easy to spot, where you have your tonic phase, you get stiff, maybe a bit of head turning, and a bit of a vocalization, the frothing at the mouth, and then the clonic phase, which looks like that. And so it's rhythmic, relatively small movements that are symmetric. But then there's all sorts of partial seizures, right? So auras of déjà vu or jamais vu, where you have the impression that you're seeing something that you've never seen before, but you know you've seen it before, or a déjà vu, which you think you've seen something before, but you haven't seen it before. So these are typical auras. Or other aura, sometimes a rising sensation. It's quite common. People go like this. They feel this sense of rising in their chest, and they cannot describe it any further, and that can be an autonomic aura to a temporal lobe seizure. A funny metallic taste in the mouth. So blank stares is really important. So if you have somebody with their first generalized tonic-clonic seizure come to you, you want to ask, have they had any funny stares prior to that? You're looking for complex partial seizures or focal seizures with alteration in level of consciousness, they're called now. So you want to look for other little turns that could be clues that this could be the second event. Automatisms are usually lip smacking, funny movements in the mouth, and then obviously fits. What you want to ask for is if there was any post-ictal phase, so did they come right to or did they not? Because the main differential, there's syncope, so you want to differentiate syncope from seizure, vasovagal episodes from seizure, and then there's non-epileptic seizures, right? A functional presentation. So that's actually the most common one we probably deal with when you have somebody with generalized fits and you're worried about that they're non-epileptic seizures. So you want to make sure that if they've had a long fit, that they're post-ictal. They're going to take a little while to come around. They'll be confused for a while and feel fatigued or groggy, out of it, combative. Now, tongue biting. The tongue biting that occurs with an epileptic seizure is on the sides. They chew up the sides of their tongue and click down their molars, and their tongue gets caught, and there's often a sort of a rippled look to the tongue. Now, sometimes people with non-epileptic seizures will bite their tongue, but it'll be the tip of the tongue, and so it'll be quite different tongue biting. Urinary incontinence is not particularly predictive because that's something that can be quite easily mimicked. But if you do have it, maybe weighs a little bit towards a epileptic seizure. The jerks, I showed you the jerks of an epileptic seizure. Often what you have with non-epileptic seizures is you have asynchronous movements or bicycling. You have hip thrusting, it's quite common, lying on the bed, going like this, which is not typical, head shaking side to side, those kind of features. I think I have a little bit more on the next slide. And then syncopal seizure is an interesting phenomenon. That's not a primarily epileptic seizure. It's a syncopal event that results in a seizure. So these are people who pass out. If you go to the ground, if you have reduced blood flow to the brain, eventually your brain will seize. But it's usually just a couple jerks and then it stops. It's not usually a full-blown fit. And you have to kind of decide what's first, chicken or egg. You know, did they pass out first and then seize, or was the seizure first? And often it requires an EEG and monitoring. But if they've been standing up and they feel woozy, they have that typical vasovagal prodrome, then they go out and have a couple jerks. That's more likely to be a syncopal seizure, which is more sort of something that you see in young women with POTS syndrome, tachycardia syndrome. So a little bit more non-epileptic seizures, because it's actually a really common thing. So 50% of status epilepticus we see is non-epileptic seizures. So it's a real common problem. There's some studies that suggest that 30% of people with epilepsy will also have non-epileptic seizures. So so there's a lot of overlap. And you have to sometimes tease it out. And just because somebody has non-epileptic seizures doesn't mean they don't also have epilepsy, and vice versa. So it can be a little bit tricky. So I already talked about hip thrusting, head shaking. Eyes with non-epileptic seizures, eyes are typically closed rather than open. It's not that good of a predictor, but the closure is helpful. They can be really long. So if you have a patient who has been seizing, fluctuating, seizing, not seizing for 2 hours, if you have an epileptic seizure that long, you're in bad shape. So you're not going to wake up, you're going to be out for a while. And often these people then just wake up and are fine. So it's that post-ictal period is one of the most helpful features to determine a non-epileptic seizure. I already talked about that. So some kind of environmental triggers tend to be more common in non-epileptic seizures than epileptic seizures, with the exception of the flashing lights. So the epileptic who drives down a road at sunset with the trees on the side and you see the flickering sunlight coming through, you'll sometimes see a seizure triggered by that. But most other environmental triggers are more typical for non-epileptic seizures. So most seizures occur not because of a particular trigger in the environment. You can have sleep deprivation, alcohol withdrawal, those kinds of things can trigger that, but not sort of an immediate thing that happens around you. I already talked about that. Sometimes it's telling where the event occurs. Does it occur in your waiting room or at the shopping mall, or did it happen in sleep when nobody was there and they just woke up with tongue biting? So usually having bystanders raises the suspicion a little bit for non-epileptic. None of these are perfect guides, but they're just sort of an indication. Now, interestingly, the psychiatric history, interesting for functional neurological problems, only about 30% of people have a true psychiatric history. So more than not will have a completely normal history. So you cannot use that as that much of a key diagnostic. And also people who have epilepsy have a high comorbidity with anxiety and depression. So it's not as telling as you might think, and you can really turn your patient off to wanting to listen to you if you investigate that a bit too aggressively and too early. But it's something to keep in mind. Family history can go both ways. So having a brother who's had lots of seizures and having seen them can be a risk factor for non-epileptic seizures. We see a lot of healthcare professionals having non-epileptic seizures because they've been exposed to what a seizure looks like. So it can go both ways. So don't let that fool you in one way or the other. So diagnosing, so if you have a true case of epilepsy, if you want to make a diagnosis, you need to have at least 2 seizures that are more than 24 hours apart and unprovoked. So not because of alcohol withdrawal or because they have an electrolyte disturbance or, those kinds of things, or medication induced. Or they have to have 1 seizure plus a 60% chance of a second seizure over the next 10 years, which you say, how do you tell that? Well, you can have an EEG or an MRI. So if you do an MRI scan and there's a brain tumor and a corresponding spike and wave discharge on the EEG, they're going to have another seizure. And so you can make that diagnosis of epilepsy and give them a medication. And that's why it's useful, so to help guide the treatment. Or you can have one of the epilepsy syndromes like juvenile myoclonic epilepsy. If you're really clear about that syndrome, then you can make that diagnosis sooner, usually on the basis of the EEG, sometimes on the basis of other clinical features. And this is something we deal with more in childhood epilepsy. The new seizure classification has two types, basically focal versus generalized. So focal seizures can either be with full awareness or impaired awareness, and they can be motor or non-motor. By generalized, we now no longer mean the possibility of a focal onset that generalizes. By generalized seizure, we mean seizures that come on in multiple parts of the brain at the same time. And they tend to be your childhood absence epilepsy, so these what we used to call idiopathic generalized seizures that have to do with chemical membrane changes in the brain, lowering your seizure threshold globally, rather than a focal structural problem that triggers a seizure. So those are the two main categories. Syndromes have stayed the same. And you can now technically be cured by epilepsy, and that used to not be the case. So these came around 2017, 16. So either the self-limited epilepsy or 10 years without seizures, and 5 of those without medications, and then you no longer have epilepsy. By the self-limited ones, I mean the childhood epilepsies that you outgrow, like benign Wellington epilepsy or childhood absence epilepsy. If you then hit puberty and you have no more seizures, you no longer have that epilepsy. So when you get somebody with a seizure, the first thing is to do the EEG. If they present acutely and have focal neurology, you want to do acute imaging, but usually they're perfectly normal by the time you see them. You don't absolutely need to do an image acutely. Most seizures are not on the basis of severe structural problems, especially in the younger people. And so you do the EEG. If it's normal or has a focality, we then do brain imaging, and we usually skip CT. So CT in a new seizure is pretty useless. So we rather just go to the MRI scan and pick the patients who really need the MRI scan. So all these people really should probably come through the neurology clinic for first seizure assessment, and then they can be returned to you for ongoing management. And then lastly, basically, we generally wait for the second seizure unless we have a really good reason to treat, like a identified brain lesion and abnormal EEG. And then the drug choice, we've increasingly moved toward using levetiracetam as the first drug of choice because it's generally well tolerated and treats both generalized and focal epilepsy. So that's some generalized epilepsies require specific medications, and there's only some that treat both kinds very well. Sodium valproate is another one, a really great broad spectrum drug, but has some problems with teratogenicity in young females. So we prefer, Keppra is just Keppra levetiracetam 250 BD, increasing to 500 BD is kind of our mainstay. But I do think there's still a role for some of the older drugs, like carbamazepine works really well, and it doesn't have that many side effects, so that's still an option. And lamotrigine is pretty popular as well, just takes a long time to titrate up. But I think Keppra is a good drug to keep in mind. The problem with starting drugs before we do the EEG is it sometimes can reduce the interictal discharges on EEG, and also once you have somebody on a drug, it's a little bit harder to get them off the drug. So if it's not urgent, we prefer the drug being started after we've done our assessment. However, if they have multiple seizures, you do want to be aware that there's this thing called SUDEP, which is sudden unexplained death in epilepsy, which sounds really scary. And when I broach this with people, I say, I'm going to tell you this really scary thing now. I don't want you to freak out. But the reality is there is this thing, and I need to tell you about it. And I say, everyone could go to bed and die tonight. It's just part of life. We die at some point, and that could happen to anyone. The unfortunate thing, when people have epilepsy, that risk is a little bit higher. And so the risk is 1 in 1,000 for the lifetime of the duration of their epilepsy might die of this, and it has to do with cardiac arrhythmias. And the risk, there's nothing really we can do to prevent that, except if they have lots of seizures, the risk goes down if we treat them with an anti-epileptic. And that's the main reason to treat earlier. So if you have somebody with lots of seizures, you might want to get them on fast. And then the second reason is injury. The seizures themselves usually are not so harmful that you couldn't wait. a little bit with the assessment. And just to keep in mind, epilepsy surgery is something that we can offer for temporal lobe epilepsy. It's pretty effective, works 70% of people become seizure-free. So it's, if they've failed a couple drugs, it's something we want to consider. We send people to Auckland for that. And then just on monitoring drug levels, just don't check the levels. Because it just confuses people. And just check, the only time I check level is if I think they're toxic or I think they're non-compliant. You know, otherwise I just titrate on the basis of their seizures. Or the seizures not controlled, I go up, and at some point they become toxic or they reach the top level, and then I just try something else. The one other time I might check a level is when they're becoming pregnant, to help monitor drug levels during pregnancy. I suggest that that's something that should probably be done by the specialist. So if you have somebody who gets pregnant while they're on an anti-epileptic, or if they have epilepsy, just refer them, and we try to prioritize those people to see them pretty quickly to get them monitored carefully during pregnancy. But the other levels, it's just I've seen so much problems caused by a low phenytoin level, because somebody then increases it and then they become toxic, and so all these drug levels interact with other things. So I would just be really just stay away from it unless you have a really good reason that you're doing something. But what happens is people just throw it in, you know, like, oh, we'll just check some lipids. Oh, they're on lamotrigine. Let me check this level. And then you get a level back and you don't know what to do with it. And then you call us and then we say, oh, don't worry about it. And we just save everyone lots of time if we just don't check it.